Thank you, sir. Thank you, IMA, and thank you, Dr. MP Jain and Dr. Pawan Goel, sir, for giving me an opportunity to speak. And Dr. Jain, thank you for so kind words. Definitely, हमारा आजकल का जिस तरह का lifestyle है, diabetes and hypertension are increasing, and that's why we are having a problem. So, without wasting time, directly I will go to our slides. So I'll be dealing with very basics of the kidney transplantation. It's like just for increasing awareness, and we should know what basics of the transplant. Any question, whatever you feel, please feel free to ask me. So what is the CKD definition? As you know, chronic kidney disease, generally we see the only the abnormality of creatinine, increased creatinine, we take it as a CKD. No, but any abnormalities of any kidney structure, function, which is present for more than 3 months account for the CKD definition. Either it could be a persistent albuminuria, any urinary sediment abnormalities, electrolyte abnormalities caused by the tubular disorders, any histological abnormality, structural abnormality, if we see during the imaging creatinine is normal but we have got a contacted kidney, or decreased GFR of less than 60. So this was our traditional CKD classification, stage 1 to 5. Like basically first only the GFR was considered. But now this is a heat map diagram where albuminuria is also included, so that its awareness increases. Diabetes and hypertension, they have a albuminuria, so we classify according to this. And A1, A2, A3 is the one. Green is the safest one. Yellow and if it is a orange to red, that becomes worse. So when we do a kidney transplant, kidney failure, when it's a CKD stage 5, GFR is less than 15, and we start preparing them for a renal replacement therapy during the CKD stage 4, when the GFR is between 15 to 29. So what is the incidence? As we know, the global estimate prevalence was 1 in 10 adults in 2020. And CKD, it is expected to be the 5th most common cause of death by year 2040. So it's estimated that more than 1 in 7 US adults have chronic kidney disease. And what is the irony? The biggest thing is 90% of people with stage CKD 3 doesn't even know that they have a chronic kidney disease. So they are living casually, and like that awareness, and at the level of physicians, at the level of general practitioner, it's very important so that we can retard the progression. So this was published in our Kidney International Epidemiology of CKD and update into 2022. So it's extremely common. We assume that 1 in 10 has a CKD. It's more prevalent in individuals with diabetes, racial minorities, elderlies, women, hypertensive individuals. And there is an increasing death rate. So it is estimated by 2040 year, it will be the 5th most common cause of the death. And it's a larger burden in the low and middle income countries. So why this is important? So CKD occurs frequently and has devastating consequences. So this should prompt very major events so that we can prevent, and therapeutic measures which are effective so that we can retard the progression and we can slow the progression so that the CKD stage 5 can be delayed as far as possible. So what are the treatments of kidney failure? As we know, there is a dialysis which can be divided into hemodialysis or peritoneal dialysis. Hemodialysis in our country, it's mostly in-center dialysis. Ideal dialysis is 3 times a week, which is 4 hours duration. Many times patient comes to us, and even like many doctors also think that if it is just 5 days, 6 days, no. Ideally, it's minimum 3 times a week is a dialysis. If they have a very good urine output, they can do even a 2 times a dialysis a week, but ideally 3 times a week. In Western countries, if you see, it's a nocturnal hemodialysis is also common. Patient come for the dialysis, they attach to the machine 6 hours a day, and that is 3 to 4 hours. And then many persons can have a short dialysis, 2 to 3 hours short session, but then the frequency increases 6 days a week. The other form of the dialysis is the peritoneal dialysis. Bhagwan ne hame, they have given a peritoneal membrane, which is a semi-permeable membrane, and it acts as a dialyzer. But in our country, again, this is very poorly like taken it. Patient doesn't have a knowledge, and even doctors also doesn't prescribe for so many other reasons. So peritoneal dialysis, but if it is used, it is a very good modality. In Hong Kong, in Mexico, it's a PD first. First patient will be the coming for the dialysis. The surgeon or even a nephrologist also can put a PD catheter into the belly, and after 2 weeks of this, they can suggest they can start the dialysis. but as it is named is there, continuous ambulatory peritoneal dialysis. 2 liters of fluid will continuously remain in the belly, and then that has to be drained 4 hours. After a month, we can put him in them on a cycler. So they attach to the machine overnight till morning, that will take care of the dialysis. The only negative point is the 2 liters of fluid is inside the belly, so that increases the intra-abdominal pressure, which can cause the hernia, effusions, and other things. And the precautions for peritonitis is very important. But after COVID, everyone is taking care, so we know hand hygiene and other precautions has to be taken. So hemodialysis requires the access, either it's a AV fistula or a permacath, in center 3 times a week for 4 hours each. Access complications are there, and viral transmission. They can have a hepatitis B, hepatitis C, or even HIV also, which is a very commonly seen, and in peripheral it is very common. Peritoneal dialysis is a home-based therapy. It's a time-consuming, but what's the problem? Burnt out rates are very high, and peritonitis risk is there. So ultimately, choice of treatment is based on outcome. What is the survival? What is the cost effectiveness, quality of life, and whether patient can do the modality, whether they understand the modality or not. So renal transplant, this is considered as the best modality. What is transplant? When a healthy kidney is taken from one person and it is surgically placed into someone with a end-stage renal disease. So this kidney can be either from a live donor or from a deceased donor, the cadaveric donors, brain dead one. And the kidney transplant is a treatment, but it is not cure for the kidney disease. So this we have to understand, this is not a cure, this is a treatment, and they have to be regularly on the medication. And one most common myth, we don't remove native kidneys unless it's medically indicated. So this is a third kidney which will be placed into the patient. So why we should talk about the kidney transplant? Why we are having this talk? So rising crisis is there. CKD, chronic kidney disease, and end-stage renal disease are rising rapidly in the India. Dialysis limitations are there. It's life-saving, but again has significant constraints. Many times you will see patient is coming for a dialysis when they are breathless, when they have a loss of appetite 4 to 5 times like in a month. They will come once a week, or when the problem is there, and that's why they get the excess fluid removal. They'll be in a like very weak stage. So that limitation is there. So kidney transplant is a gold standard, and it improves the survival and the quality of life. And as a general practitioner, whosoever is a physician is there, surgeon is there, also they have a very key role so that we can prevent and retard the progression. So kidney disease burden in India. So this is approximately, we see that approximately 200,000, 2 lakh of patients, new ESRD patients are there every year. And less than 10% get evaluated. They are not even given a choice of the transplant. And patient also has a myth like the transplant kidney doesn't survive for a longer time. 90% are the living donors in our country. Like disease donor rate is only 0.8% per million population. Like it's irony that living donor, we are having like so much education, but and especially please don't mind, our North India lags behind in the disease donor kidney transplant. If we see the Gujarat, western side or the south, they are much ahead in a disease donor rate as compared to our North India. So what is kidney transplant? Healthy kidneys placed in the lower abdomen in the right iliac fossa most commonly. Native kidneys are usually left in the place. New kidneys take over the filtration immediately as soon as the anastomosis is done. And lifelong care, they requires a lifelong immunosuppression. That's very important. So why kidney transplant is preferred over dialysis? Survival benefit. 10 to 15-year longer survival as compared to the dialysis. Quality, better mobility, better daily functioning. They can do their normal activity. And one more thing, better consumption of the food. They can have like it should be properly cooked, fresh food, but they can have everything what anyone normal person can have. Cost effective. If you see the dialysis cost and if you see the transplant cost, after 3 to 4 years, transplant comes out to be cheaper as compared to the dialysis. And social return. They can return to the work. They can have a normal social life. Children can go to the school normally. So what are the basics of kidney transplant? So immune system, our immune system is very active. So that's why we have to be very careful for that. So self versus non-self. Body distinguishes own tissue from the foreign. Foreign recognition, new kidneys taken as seen as a foreign invader. Though might be parents might be giving or a sibling might be donating. But body identifies that something from outside has come into the body. That's why our immune system gets activated and it tries to reject the kidney. That's why they have to give the immunosuppression medication. So immune system tries to reject this kidney, and then the immunosuppression has to be given, which has to be lifelong. So this prevents the rejection, but we have to take into consideration as well as the infection rates also. HLA, this is a compatibility code. So basically, by name, either I am Manish or Dr. Pawan, this is the name which is given. But HLA is the one which tells us what is our phenotypic name. So that will be a 6 main types: HLA class 1 and class 2. So it's a ABC, it's a class 1, DR, DP, DQ antigens are the class 2. So we do this HLA, even this we can find the relationship whether by the HLA. Then perfect match, rare, but like identical twins can be there, but these are the best outcomes. And then the better matches have a lower rejection risk. Type of rejection: as soon as we do a transplant, hyperacute rejection, it's minutes to hours. There are the preformed antibodies which gets activated and it will reject the kidney immediately. So hyperacute rejection can happen immediately on the table or within 24 hours also. Though with such a potent immunosuppression, good induction, nowadays these are less, but still it can happen. Though we will do the cross match, after negative cross match only we'll go, but hyperacute rejection are decreasing, but definitely not totally nil. Then acute rejection, it can happen into the days to months. It can be an antibody mediated or a human and cellular mediated, which can be a T or B cell mediated immune response. So this will lead. And then the chronic rejection, this happens over the months to years, and there is a slow progressive graft loss. We all have to understand, as I already told you, this is not a cure of the kidney disease. This is a treatment which what we are providing. And we immunosuppressions we are giving to the patient, but there is a slight amount of the immune system like which is active, so it keeps on producing the antibodies, and slowly it leads to the progressive graft loss. So ultimately the kidney has to lose that's why they have to be on immunosuppression medications lifelong. So what are the immunosuppression drugs? Triple therapy is the standard therapy. Calcineurin inhibitors, these are the either a cyclosporin or a tacrolimus. Cyclosporin was used previously. Nowadays the tacrolimus is most commonly used. Then mycophenolate is there, which is the second drug which is used, and steroids, definitely will be getting the steroids. Before this, these are for maintenance. We start it on the day 1 itself, day 0. But before this, they get an induction therapy, which is a thymoglobulin or a basiliximab. So this prevents the rejection. But depending on the low risk or the high risk, low risk patient will get a basiliximab, high risk patient will get a thymoglobulin. Costly also, but we can do the transplant even without induction therapy also. So lifelong adherence is essential for the graft survival. So what are the types of the transplant? What are the indications and what are the contraindications of transplant? So donor types, it can be most commonly which we see is a living donor, which can be a related or unrelated, but it's a healthy individual should be there. Our spouse is an unrelated donor, but definitely they can donate the kidney. Disease donor, the brain dead donors who are brain dead and with a family consent they can give. Then there is a ABO incompatible donor. We are doing a transplant. Compatible donor is the preferred one. But suppose O is the recipient and they don't have a O blood group. So A or B can also be a donor. But we have to see how much the anti-A or anti-B titers are there. So these are the one ABO incompatible. But for them, it's a special protocol and we have to give them a rituximab and further therapy. We have to prepare them for a transplant. Chances of rejection and infection will be there. And then the paired exchange. Our rules suggest this, that paired exchange can be given. If a donor and a recipient are A or B and the other pair is there, so they can swap the kidneys. So if a compatible living donor is not available, then you can be put on a kidney transplant waiting list to receive a kidneys from a deceased donor. How long you have to wait? It depends on the availability of the organ. And then there are few points which we have to register them on the NOTO site, and accordingly the list is generated. Any hospital doesn't have their own list. It's through the NOTO and it comes from the proper guidelines. Then only they can have. We don't ever say that anyone can be bypassed and they can take. Survival, this is USRDS data of 2012. If you see the kidney transplant, which is in red, dialysis. So at 1 year, dialysis rate is almost same, but transplant is definitely better. But as years pass by, 5 years or 10 years, you can see the transplant rate is much, much better than the dialysis. So this is a living versus disease outcome. So disease outcome, 1 year survival, like 10-year survival, or that is less as compared to the living donor, because what is the age of the deceased donor, what was the cause of the death, so many other factors are there. Immediate function also, live donor is much better as compared to the deceased donor. What are the common causes of chronic kidney disease and say renal disease? Diabetes, which is the most common cause, almost 40 to 50% of cases what we see is due to the diabetes, uncontrolled diabetes. Hypertension. So almost two-thirds of our chronic kidney disease are due to the diabetes and the hypertension. And if we see among ourselves also, in doctors also, doctors are very poor patients. If we have a diabetes, if we have a hypertension, we'll try not to take medication. We'll see, no, it will get cured. अपने आप ठीक हो जाएगी. नहीं. We should take it and cure it in the initial stage itself. One medicine we should, if it's there, that should be taken regularly. Then glomerulonephritis are there, which could be IgA nephropathy, FSGS, lupus nephritis, so many things, almost 20%. And then the 15% polycystic kidney disease, hereditary disorders, or the other disorders are there, which are causes of end-stage renal disease. Risk: kidney transplant can treat kidney failure, but isn't a cure, as I was addressing before. Some forms of kidney disease recur after transplant. That's the recurrence of the disease. This is also commonly seen. Diabetes will come into the, again, that recurrence will be there into the transplanted kidney also. So they will start have the albuminuria, it might progress later on. And then if we do a biopsy of a graft kidney in a diabetic patient, the recurrence, we can see the diabetic nephropathy changes. That then disease like a MPGN, membranoproliferative GN or FSGS, in those also recurrence is very high, as like IgA nephropathy also. So we have to understand and we can't predict it. So after transplant also, their basic disease can recurrence. Sometimes basic disease is not known. We do a graft biopsy after there, even a renal dysfunction, proteinuria is there, then we can get a de novo disease, but we are not sure that that could have been a basic disease also. Then risk associated directly with the surgery, rejection of the donor organ, which is bound to happen over the time. So acute or chronic, as I was discussing, antibody mediated or a cellular mediated, this is a side effect of the immunosuppression. As the name is evident, immunosuppression, it will suppress our immunity. So they become more prone for the infection. So any fever, anything is there, they have to immediately come to the nearby physician or a doctor so that it can be addressed easily. Then diabetes, know that they are continuously on the steroid, so they can get, know that, new onset diabetes after transplant, or rarely even cancers are also seen. So when deciding whether kidney transplant is right for you is a personal decision, and that deserves careful thought and consideration of serious risks and benefits. So we have to discuss all the pros and cons. They have to sit among the family members and then take a call. But definitely transplant is the best modality for them. For certain people, kidney transplant may be riskier than the dialysis. Who, any advanced age, who are very frail, we know they won't be able to tolerate the surgery. Severe heart disease, they have a severe heart disease, pumping is not good, and they might not be even able to tolerate anesthesia also. Any active or recently treated cancer, dementia or poorly controlled mental illness, the one who doesn't have a ability to think whether they can take a medicine or not, or any substance dependence, is there alcohol dependence, or we see the patient has got a psychiatric problem, they won't be able to take their medication, so they are not a good candidates for transplant. Absolute contraindication, active malignancies, untreated or recent cancer, as I was telling you, any active infection is there, tuberculosis. If anyone has a tuberculosis, they can definitely have a transplant. Many centers have different protocols. Some take after 3 months, some take after 6 months. But we in our center, after 6 weeks to 8 weeks, if they are better, we take them for a transplant. Rifampicin generally we avoid after transplant. So they will stop the rifampicin. It has got a severe interaction with our CNIs. So and other drugs continue. Any active infection is there, they are not taken. Irreversible cardiac condition and others, as I was discussing. So part 4, this is a donor and recipient selection. Who all can donate? So live, it can be related, unrelated, or a cadaveric donor. Blood group compatibility, as it is in the blood transfusion, O is a universal donor, AB is a universal recipient, same as blood transfusion. And here the good part is RH group, whether they are positive, negative, it doesn't make any influence. So positive can give to negative, negative can give to positive, that's not there. Ideal donor age is 18 to 65 years, but we have taken, if healthy, donor as a 70 or 75 years also. Non-diabetic donor, we don't accept diabetic as a donor. Mild hypertension with no target organ damage. And then the tissue match and HLA match should be there. Donor selection, GFR we check, it should be more than 80 ml per minute. The split GFR of each kidney should be 40 ml approximately. There is no systemic disease or infection. They should be fit for surgery. Surgical mortality is seen as 3 in 10,000 patients can have a surgical mortality, but not because of the kidney. This is as a surgical mortality. And long-term effect, they can have a mild proteinuria, so they should control your blood pressure. They should avoid the unnecessary painkillers and NSAIDs and native medication and a careful, simple lifestyle. Mild hypertension is seen in 17% of the patient, and experience they have a good survival. Rather, many patients get screened up, so their survival is better. Otherwise, we won't get screened up for these tests. So this I was discussing you. O is a universal donor. For recipient O, the donor can only be O until unless it's a ABO incompatible. For recipient group A, donor can be O or A. For B, it can be B or O, and for AB, anyone, O, A, B or AB, irrespective of the RH factor. Evaluation, we have a detailed evaluation of the donor as surgery, the donor and recipient before surgery, whether you are healthy enough to give surgery, whether you are will be able to tolerate immunosuppressive medications or not, have any medical condition that would interfere with the transplant success, and are willing and able to take the medicines. Evaluation requires a good history, good thorough physical examination, imaging studies, blood tests, psychological, psychiatric evaluation of both the donor and the recipient, and any other necessary testing. They will give it a cardiac evaluation, urological evaluation, all this. And if any further is required, they get further. For gynecology, ladies, gynecological evaluation is also must. So recipient eligibility, they should be on dialysis, they should be suitable for surgery, diabetes and hypertension should be managed, and a strong psychological, they should be like sound mind. Living donor eligibility, 18 to 65 years, healthy donor, they should have a normal renal function, GFR should be more than 8, they should be able to give them informed consent themselves. They should not have any diabetes or uncontrolled hypertension. So this is the battery of the test, like this is the donor evaluation. First we'll get a routine biochemistry, which is a KFT, LFT, sugars, HbA1c. If fasting or PP comes deranged, HbA1c normal, we'll get the oral glucose tolerance sense also. Then urine examination, urine protein creatinine ratio, urine albumin creatinine ratio, basic test, thyroid profile, lipid profile, hemogram, coagulation. Then to see whether the infection, there's CMV, Epstein-Barr virus, varicella zoster virus also. Serology is there, blood group is must, cardiac evaluation, radiology, X-ray is there, ultrasound, CT, angio for renal vessels. Then after these are there, we'll do a DTPA renal scan to see their split GFR function, PSA for the gents, mammogram, gynecological evaluation for the females, psychiatric checkup and clearance, and then ultimately we go to the HLA typing and cross-match. That's the last test. Same is for recipient. We go ahead further, cardiac evaluation. They will have a stress echo, or diabetics we prefer if they can have an angiogram also. Donor and recipient, they can have a CT chest also, depending on the condition, how is their lung status, PFT and other tests as required. So before finding a match, we do a blood typing, preferably to get a kidney from a compatible donor. Incompatible blood type is possible, but they require a more medical care. These transplants are known as a ABO incompatible transplant. The infection rejection increases, and cost factor also can go enormously high. Tissue typing, HLA has to be done. Then cross match, very important. We do a cross match. This is a CDC cross match and a flow cytometry cross match, in which small sample from the blood donor as well as the recipient cells, they are matched, and we see the cross match. What is the number of the cell deaths? We assume that less than 20% of the cell deaths we take as a cross match as a negative, and they can be the donor. But if it is positive, we have to see further donor specific antibodies and further test what is there, but the chances of rejection and the things increases. So negative cross match means blood are compatible and body isn't likely to reject the donor kidney, but still after you do the transplant there are some other preformed antibodies also, non-HL antibodies also, which can be there and which can lead to the rejection. Positive cross match is possible, but again they require an extensive treatment. So during the procedure, kidneys surgically placed in extraperitoneal iliac fossa, renal arteries and ostomas with recipient's internal or external iliac artery, vein with the recipient iliac vein. So pre-op, final cross-match and anesthesia clearance, surgery, 3 to 4 procedures is there, and then recovery, surgeon, this recipient stays 7 days after the transplant, 5 to 7 days if it's a robotics, and 7 days in generally. So 10th day mostly they get discharged. Early post-transplant care, they stay in ICU 3 to 4 days. After that, they are shifted to the room. Functional assessment is there. The daily urine output, KFT, CBC are measured. POD5, we will do the liver test. Otherwise, protocols are there. We do all the tests accordingly. Immunosuppression medications are started from the day 0. If it's a ABO incompatible transplant, we started 2 weeks earlier. Then infection prophylaxis has to be given. Mobilization, gradually we increase their activity and then we plan the discharge activities. Long-term monitoring, in first month we see them weekly twice, in second month we see them weekly once to fortnightly once, 15 days once. From the third month to first year we see them, this is we are talking about the recipient, monthly once. Then second year, every 1.5 to 2 months, slowly we gradually keep on following, but long term, every 3 to 4 months we encourage them to come for the evaluation. After the successful kidney transplant, new kidney will filter the blood and will no longer need dialysis until the rejection is there. To prevent from rejecting, they need medicines to suppress the immune system. So this anti-rejection medicine make body more vulnerable to infection. They require a prophylactic antibacterial, antiviral and antifungal medication. It is important to take all the medication as prescribed at a regular timely interval. We don't generally suggest that the immunosuppression interval should also be changed. And this body can reject the kidney if we skip the medication even for a shorter period of time. So surgeries carries a risk of significant complication. Blood clots can be there, bleeding can be there, leaking or blockage of the tube can be there. That links the kidney, basically the ureter. Ureter kink can be there, urine leak can be there, infections are there. Then again the rejection, infection, cancers in a long term or a cardiovascular outcome. The cardiovascular, they have a increased cardiac morbidity in the first month post-transplant, but after that, ultimately, their cardiac things get better. No doubt, this is a new onset diabetes after transplant. Dyslipidemia, weight gain, and the lipid abnormalities are continuously on a steroids as well. The calcineurin all contributes to disease. Bone disease, osteoporosis, avascular necrosis. This is also seen because of the steroid, and that's why they require aggressive risk factor controlling and monitoring. So causes of death in kidney transplant, this was a earlier data, but I thought it's the best one. So cardiovascular disease is the first most common cause of a death after the transplant, which is closely followed by the infections and then the malignancies, and there are the unknown causes also. So what are the quality of life come? Marked improvement in daily vitality, liberation from the daily dietary dialysis restrictions, 90% return to the work or school, and greater autonomy and well-being. So just I would discuss, it's an entity which is called as a preemptive transplant also, where we know that they get a transplant before starting dialysis. We know they've reached the CKD stage 5 and we have complete the donor workup. So as soon as we know they're ready for the transplant, without going for dialysis, they can be taken up for the transplant. The issue with this is patient never get that importance of the transplant, because once they are on a dialysis, they will come to know what are the suffering, not in that way, but what are the difficulties they face, what are the suffering. So after dialysis, the value of transplant increases. The other part is like we are going to bargain anything in a market. So patient always thinks I would not have required transplant. Might be I would have been without transplant for 3 months, also 6 months. So that again becomes very difficult to explain to them. And swap exchange or a paid exchange, as I was telling you. So suppose kidney swap donor 1 is there who is a blood group A, but his recipient wife is or any other relation also B, but so they can't donate. We can do a ABO incompatible, but then the cost and other things will increase. So there is a other pair whose blood recipient is A and they have a blood group type B, so they can donate. But this can happen only in A or B. O is a universal donor, so our laws don't allow until there's a cross match is there and he takes as a special consideration. Robotic renal transplant, this has gained popularity over the time. So traditionally kidney transplants were done by the open technique. So newer technique, minimal invasive surgical procedure called the robotic assisted renal transplant. They require a special expertise in the robotic surgery and high-end equipments. And this was the like Verticuti Robotic Institute, which was started by the Medanta, and from our institute, the surgeons went to even US and the other countries also to teach them the robotic transplant. Smaller incision is made to remove the kidneys from the donor. Smaller incision is made to insert the kidney, and these are the small ports like a laparoscopic cholecystectomy, which in which way it sees. So you can see the incision between the open technique as well as this robotic technique. Lesser wound complication, faster healing, lesser days with a drain, reduced blood loss, and improve aesthetic outcome. But ultimately, overall results are same in a longer term. For a female who has to wear a sari, it's a robotic transplant. They won't be able to know the scars also. So just I'll tell you briefly about our transplant experience at Medanta. Since its inception, since February 2010, we are doing all the transplant. I am there since 2010. We do all type of transplant, including preemptive transplant, paired kidney exchange, early steroid withdrawal. We have done a steroid free also. We did a trial, but we found the rejection rates were high. So we are not doing any more steroid free transplant, ABO incompatible. Robotic renal transplants are there. All donor nephrectomies are laparoscopic. So this was a 2023 and 24 transplants. How many we have done? Like this was a 228 in 23, 224, 241 in 24, and all types of transplants are done. If you see the live donor, out of 228 and 241, 225 were live, and in last year 240 were live. We did only a one cadaveric transplant, and that's shame for all of us. Like such a big hospital, Delhi NCR, in all the places, cadaveric transplant is very poor, which can be increased. That at school level it should be there, because as a nephrologist we can't ask the neurosurgeon as to see the brain dead one, and there are so many other ethical legal issues also which are there. So this is a patient survival. So overall, this is till 2023. We have done 3,000 plus transplant. 2,600 were open. Robotic were 257. Only you imagine, not even like a 1%. 22 transplants were a cadaveric transplant. AVO incompatible, we did 202. SAPs were 118. That was very good. Preemptive also 448. We have done a hepatitis C, hepatitis B, and HIV transplants also. Second and third transplant. Second transplant, like after their graft dysfunction is there, they failed the kidney. 123 patients got a second transplant also. So this is just a other type of diagram. Robotic 240, same one. So this is our overall survival. Recipient mean age is 40 years. Donor mean age is 47 years. And as per surprising, donor recipient age, most of the recipients are the males. And 90%, 80% to 90% donors are the female. In our country, especially in our northern part, the donor will be either wife, mother, sister, or bua. So if spouse is there, wife is the most commonly donor. If husband is like wife is getting a kidney, husband will get a new wife, but many times they won't donate. So this is a like irony again, and whatever gender bias is there, still it is there. So 90% of the donation is being done by the female. Mean dialysis vintage was approximately 5.5 months, and HLA mismatch was 3.75. So outcome, patient survival is 90%, death censored graft survival is 95%, biopsy proven acute rejection, which matches all the world standards, 15% acute rejection, infections are 25%. In our 9 patients had a PTLD. This is a post-transplant lymphoproliferative disorder cancers. 9 patients out of these 3,000 had these. And know that 250 and 10%, but this is the one in whom it persisted. Majority of our population was a diabetic, so their diabetes can also get worsened, so that active control is very important. And few patients initially when steroid dose are high, they will get a diabetes, which improves subsequently. But suppose their family history of diabetes is there, the chances of diabetes getting is again higher. Infections, UTI and pneumonia are the most common infection. During the COVID time, almost our patients had a maximum number of the COVID, so 27% of patients had a COVID. We see all sort of infection, cytomegalovirus, tuberculosis, herpes, all these infections are common. So it's a very delicate balance which we have to manage between the immunosuppression as well as the rejection. So dear friends, dear colleagues, seniors, what are the key concepts? Kidney transplant is most cost-effective modality of renal replacement, sorry. Transplant patients have a longer life and a better quality of life. Earlier transplant, which is a preemptive transplant or within 1 year of dialysis initiation, yields the best results. Living donor kidney outcomes are superior to disease donor outcomes. And success of transplant results from a delicate balance between the suppression of the immune system to prevent rejection and the long-term side effect of the immunosuppression. So there is nothing like a successful kidney transplant for doctor also and for the patient. Imagine this is the life. This is the our all Medanta nephrology team. I am there here and my all the team member, doctors and the staff. This was in 22 after the COVID. We took out a kidney awareness walkathon was there so that the awareness is there. Everyone is aware of the cardiac disease, neurological disease, but for kidney, again, it's lacking even with doctors also. And this is with Dr. Terhan, myself, and our surgeon Da Vinci robot, which we are opening. And this after finishing the 3,000 kidney transplants, which just a small thing with the team members. Thank you for patient hearing. This is again a kidney which was done by the one of our patient do it and had a posted it on the World Kidney Day. Thank you, everyone.
Thank you, Dr. Manish, for the wonderful talk. And we have some questions in the chat box.
Sure, sir.
I'll read them for the participants. From our past president, Dr. Karan Punia, there is a question. Donor issues of not being close and blood relatives are more in North India and perhaps relaxed in Kolkata. Is it true? As otherwise, organ donation rules are same everywhere in the country, or does it vary according to the state rules?
No, sir, it's a NATO rules are there and the HOTA Act is there, which is universal and all over the country it's there. So we don't take unrelated donors. Even if we are taking a spouse, most of the times we'll take though it's not recommended, but we'll do a HLA with a child to prove the relationship that they are a real husband and wife. So this is there. Regarding Calcutta, I won't comment, sir. See, 1% of the things are there, which we don't get into this. Definitely, I don't know about Calcutta, sir, so no comments about that. But definitely, we do only the related transplant. If there is not in the family, then they have to see how is there, like, but we take a related transplants only. Like it is a first degree relative which we prefer. Either the parents are there, siblings are there. Most of our patients don't take in this part as a like children kidney, but they can also donate. Grandparents can also donate. But if these are not fit, even in-laws can also donate. But then the committee has to pass through it. We will put into the papers for. But for our point of view, so suppose in-laws are there, brother-in-law, sister-in-law is donating a kidney, we'll do a DNA HLA for 4%. Husband, wife, child will prove the relationship, and suppose it's a husband, sister is donating, then we'll do a HLA also. So in that way, we'll prove the relationship. We'll put the papers to the committee. Its final call is by the committee.
Thank you, sir. Thank you. There is another
Dr.
question.
Pawan,
Yes,
one minute, please. Yeah?
Yeah.
Sure, sir.
One of my friend is a very busy physician, and he had to go for this thing. He visited Gangaram Hospital and most probably your hospital as well. So his two sons, both are doctors,
Yes,
and
sir.
wives are also this thing. Daughter-in-laws are also doctors, and blood group of the both sons is the same as of the doctor, but they don't want to, as you said, they don't want to donate.
Yes, sir.
Then they went to Kolkata, and there it seems they took one servant who is a very long related to them, staying with them for quite a long time. And then this thing, what I was, and I was surprised. How come that she can donate it? They said, no, she can donate. In Kolkata, it is there. I said, I have never heard about this thing. But still, if it is there, I think something is wrong. And ultimately, they also said that this compatibility is not good, and they sent her back. Today itself, she informed me that her husband doesn't need, although he's got a fistula in the hand, he doesn't need hemodialysis also, and he doesn't need kidney transplant also. Earlier, they visited twice to at Calcutta, and they told that you first go and have a dialysis and then come to us. I said, why dialysis? When your kidney is okay, your urea is okay, why? So ultimately, I think they told them out. They sent them out saying that they did not want to take the kidney of that servant,
Yes, sir. Sir, we don't take a unrelated donor, sir. And I don't know about the Calcutta and don't want to comment also. So there
No,
are so many.
yes. I also didn't want to mention it, but it was surprising to me. My son is also a kidney surgeon.
Okay,
So
sir.
he's at Hisar and passed off from Jaipur,
Yes, sir.
Mahatma Gandhi. There also lot many transplants. Sudha Sukhi, you must be knowing, is doing lot of things. He was a faculty
Yes,
there.
sir.
That's why I was surprised. How come that in Calcutta it is relaxed? Sorry,
Yes, sir.
I didn't want to mention Kolkata, and let me deleted that I was talking about Kolkata.
Sure, sir. Definitely, sir.
No. Okay, sir.
There
Thank
is
you.
another question from Dr. Rakesh Singla. Sir, if any young healthy female comes for minor surgery like hysteroscopy and dilatation and curettage, do we need to ask for routine creatinine?
So it's always better. We don't know, like, if suppose any urinary abnormalities are many females, suppose they are there, any, because as I was telling you, CKD will be going undiagnosed for years. So there is no harm in getting the creatinine as a basic test and our urine routine in a proper. But creatinine should be, I personally think that there is no harm in getting, since you will be getting hemoglobin also, simple serum creatinine, it should be done. It's always advisable.
Thank
And
you.
nowadays, like, it's done easily. You get the results in 2 hours also, and it's not costly also. Serum creatine, complete RFT can be done at like places between 100 to 500 rupees. I think it should be done.
Uh, Thank you, Dr. Manish. Sometimes it happens, patients came for the surgery and the previous PSC has not been done. And surgeon wants ki nahi, nahi, don't wait now. We will ask for creatinine, but they refuse. Sometimes
But
some
doctors,
muscles.
yeah, Dr. Singla, this can happen. But if we see our safety also, suppose the patient by chance having a CKD earlier and your things worsen later on, whatever you by chance you have used any like diclofenac is commonly
Yeah,
used,
diclofenac, yeah.
or even like aminoglyc, suppose then everything will be attributed to that. And again, like the hypotension by chance it has happened, or a pre-renal dehydration, so everything gets attributed to that. But if you know the basic value, you can easily explain that this
Easily,
patient
yeah.
is being taken as a high risk. So as like personally, I would suggest to get a renal function test. There
We
is
also
no
ask for
harm.
it
Yeah,
sometimes
but
because of surgery.
even like suppose you have to take it emergency, you're withdrawing a blood, send it for a sample. At least you can tell the
Okay,
patient that this is the sample which was taken before the procedure. And if dysfunction is there, it's easier for us also to explain.
yeah,
And patient
okay.
management also improves very like in effective manner.
Thank you. Thank you.
Thank you, Dr. Manish. It was really very enlightening and very comprehensive talk. Thank you very much.
Thank
Just
you.
one question.
Sure, sir.
Is unrelated transplant is permissible under the guidelines of NOTO?
Sir, emotional act is there, sir, definitely, but the committee takes into consideration and lots of factors are there. They take into the education also, they take as a, like financial things also. There should not be financial transactions. But that's a very thin line, sir. So we don't take as a unrelated transplants because then it's opening the Pandora box and things get in that way.
And is there any provision of insurance, especially health insurance and life insurance, in the guidelines for the unrelated donors in under the guidelines of NOTO?
I don't know about insurance, sir, because I'm not sure, sir.
Right.
So there are two,
Thank
three
you so
questions
much.
from my side. Uh, Dr. Manish, can we take up patients with the history of treated tuberculosis for renal transplant?
Yes, sir, definitely we can take, but we'll get a prior HRCT test or some this plain test. We can take. We can take even a patient who are on anti-ATT also, currently undergoing anti-tubercular medication. Minimum 1.5 to 3 months we wait so that it gets treated. We will hold the rifampicin before the transplant a week before because it has got an interaction with CNIs, and then our CNIs level won't be there. So the chances of rejection increases in that way.
Yes.
So ideally, like depending on their tuberculosis, whether it's a disseminated or it's a mild one, whatever. So minimum, like we'll wait minimum for 6 weeks, but we can definitely take. And treated tuberculosis is not a problem.
Sir, what is the incidence of reactivation of tuberculosis in our renal transplant patient?
So
after
reactivation is definitely higher than the general population. So we keep a close watch. So suppose any active tuberculosis there, as we are giving an induction therapy, in these patients, we won't prefer a thymoglobulin. If required, we'll give a basiliximab, which is a low risk one and a less potent as compared to thymoglobulin. Because as soon as we go for a higher immunosuppression, higher induction therapy, their immunity further goes down and the chances of infections further increases. Tuberculosis definitely in our patient is much more as compared to the normal population. As I was telling you during COVID also, our patient had a COVID much more than the normal population.
Another question, has the SGLT2 inhibitor and ACE-ARB improved renal outcomes and risk of renal transplant in our patient?
Definitely, ACE, ARBs and SGLT2 inhibitors retard the CKD progression. So ACE or ARB should be given for any proteinuric patient who is hypertensive and even a diabetic proteinuric patient, even his blood pressure is normal with the monitoring. And after this SGLT2 inhibitor, wherever indicated, definitely we give them. So this will retard our chronic kidney. Albuminuria gets corrected, other factors also improve. So definitely CKD progression is delayed by these agents.
And the final question, cost of renal transplant in Medanta and monthly cost of post-transplant medicine.
Sir, approximately 1.5 lakhs if everything is okay, extra we don't do anything, or up to 2 lakhs is the donor and the recipient evaluation. Until unless they go for a consultation and they are asked something else, then the transplant cost package is approximately 7.5 lakhs with induction therapy, which costs approximately 1.5. So without induction, it's approximately 6 lakhs. So somewhere between 8 to 10 lakhs is a total therapy of the transplant. After that, they require approximately 15 to 25,000 rupees medicines in a every month, which can go down to 5 to 15,000 or even more also after 6 months to 1 year of the transplant. But that depends on the tacrolimus level, how much medication requirement is there for them. The patients who are below poverty line or who are we are getting lots of fund from the PM relief fund, CM relief fund. They have to go to the window, MP and MLAs, they all have got the funds. They should apply over there. They'll come to us if we find the evaluation. We do the donor evaluation. We'll issue a certificate that such and such person is the one, and this patient is the most likely donor. So they apply for that, but they won't get the money in their hand. That come to the hospital because we are getting in PM window also directly they can apply. So there have to the certificates and other things. So money comes to the hospital. Within 3 months, if transplant doesn't happen, that money is goes back to that fund. So that is also there. Even many corporate social services, CSR also, if they apply, they also help for a transplant. So medications, definitely cost is there. We tell them to have 2 to 3 lakhs definitely extra because post-transplant, if any complication is there, that costs extra, and that immunosuppression cost should be bearing. What, like one of my school junior required a transplant, we made a WhatsApp group, everyone contributed from 500 rupees to 5,000, even more also. So most of the transplant from 8 lakhs, 5 lakhs got covered into that. But after that, immunosuppression medication is there, so they should be self-sufficient for those medications also. Many governments like Rajasthan government is there, and many countries they are giving the immunosuppression for few times, even like for at a subsided rate also.
Thank you, Dr. Manish. Any other question from any other participant? Dr. Ranveer, Dr. Ashok? Any questions, sir?
Any
If,
precautions for the donor?
Donor,
No,
they
sir,
should
it
not take
it was
any.
a good presentation, sir.
Thank you, sir. They should not take any painkillers. NSAID should not be taken. If their blood pressure should be annually monitored. After they give a kidney, we get their evaluation routine blood tests like after 3 months, even including the spot urine protein creatinine ratio and the ultrasound. Then after a year, we encourage them for every annual yearly checkup so that we can evaluate. If there are on antihypertensive, the blood pressure should be regularly monitored and they should take their medication regularly. Simple lifestyle. Whatever our elders used to say, less salt diet, regular exercises, which everyone should follow, the same things they should also follow.
Thank you, sir.
मनीष, कभी ऐसा देखा गया है कि किसी डोनर के बाद में फॉर एनी रीजंस नाउ सिंस द डोनर इज हैविंग ओनली वन किडनी and the donor was young at that time when he donated the kidney, after some year he or she himself had some problem like diabetes or hypertension,
Yes, sir.
and
Diabetes to
then
sir.
she also needs transplant.
Sir, dialysis is there. Diabetes is there, which can like we take all the measures. We take all the family history, like how strong is the family history. We see that if suppose a strong family history is there and age is young, we don't encourage that type of the donors. Few centers are started taking a borderline diabetic donors. We are not taking yet. But like one of our lady was there who donated kidney to her son almost 20 years back. So that time she was 45, 50. After that, she became very much obese, uncontrolled diabetes. So she landed up in a dialysis 6 months back. So that lifestyle is very important, sir. That psychiatric evaluation of a donor and recipient is very important. That simple lifestyle they have to follow. Many times, so many factors are there. One patient was there who's like spouse expired, and after that, their scenario totally changed. Left all the medication and things. So that definitely then that complication can happen, sir. And with a single kidney, your tendency to get complication increases.
Thank you, Dr. Manish. It is really very nice. Whosoever attended, it was a quality audience, and everybody must have taken something from your talk. Thank you. Thank you so
Thank you, sir.
Thank
It
you
is
very
my pleasure, sir. Definitely.
And sir, next week we have very important session, survival strategies for small and mid-level hospitals. Because right now, in the wake of corporate hospitals and greater reach of insurance and low cost government policies, so definitely small and mid-level hospitals are fighting for its survival. So next week we will be discussing survival strategies for small and mid-level hospitals, and we have our past national president Dr. Ravi Wankhedkar speaking on this topic. So this is going to be a wonderful topic, and please spread the message in your colleagues. This is going to be really wonderful topic for all of us. It is going to be very useful. So thank you very much, dear friends, for attending. And thank you, Dr. Manish and Dr.
Thank
Jain
you, sir.
sir, Dr. Punia sir, and everybody. Good night.